Positive ANA and Autoimmunity Part 2 by Dr. Soloway here at After Work Rounds or Evening Rounds. So, as you recall in the last video, we've learned that if your ANA is low, it may not be very important. However, if it's high, it's always important. And today we're going to discuss what do these things mean? What do we look for? So, we have the patient with a positive ANA, and we go through a various set of questions, which can include the findings of dry eyes or dry mouth, which would be suggestive of possibly Sjogrens syndrome. However, to add confusion, you should know that you get dry eyes and dry mouth in rheumatoid arthritis, as well as lupus. We also ask about Raynaud's phenomena, which is the discoloration of a digit, such as a finger or a toe, or several fingers or toes. When exhibited, the patient will describe what is called a triple phase color response, going from white, blue, or purple to red, lasting somewhere between 5 minutes and 60 minutes. If it lasts more than 60 minutes, it is generally not Raynaud's. It would then likely be another diagnosis. But if we are convinced the patient has Raynaud's with a positive ANA, we do not say the patient has lupus because ANA along with Raynaud's can be seen in Sjogrens, scleroderma, lupus, and myositis, the conditions which I referred to in the first part of this lecture series on autoimmunity. Now, to make things a little bit easier, I'm going to make some charts here. We're going to put lupus, rheumatoid arthritis, and Sjogrens. We will also put scleroderma, and we will put myopathy or muscle inflammation. So what's confusing about this and what isn't? Well, we know that the ANA is seen in all of them. We know that the rheumatoid factor is seen in lupus, rheumatoid arthritis, and Sjogrens. We know that the SCL70 antibody is typically reserved for scleroderma. We know that in myopathy, we typically get synthetase antibodies. We also know that in Sjogrens, which I'll put up here, we get SSA and SSB with rheumatoid factor. All that being said, I apologize for writing ANA and rheumatoid factor and then changing to diseases. Remember, this is evening round, so I'm not necessarily at the top of my game, but hopefully I'm making sense to you guys. All the conditions here, lupus, rheumatoid arthritis, Sjogren's syndrome, myopathy or muscle weakness diseases of inflammation, and scleroderma, which is a mixture of inflammation and fibrosis or hardening, they all have positive ANA. So the ANA cannot diagnose anything, however it is seen frequently. This means it is a sensitive test, however it is not specific for any one disease. Now, when we have the ANA, we will look for disease-related antibodies that are specific. So in the case of lupus, we have to have an ANA and a double-stranded DNA. We do not, and we never check, single-stranded DNA. It is not useful in clinical practice. We occasionally check what is called a histone antibody, and this is for DLE or drug-induced lupus. Drug-induced lupus. In rheumatoid arthritis, we often can confirm diagnosis by having cyclic citrinylated peptide. So if a patient has rheumatoid factor and CCP, even with an ANA that's 40, 80, or 160, that person would have rheumatoid arthritis based on their clinical examination. In Sjogren's disease, which is typically featured by dry eyes and dry mouth, but can involve other body parts. Usually there is a rheumatoid factor with SSA and SSB, which are Sjogren's specific antibodies, the SSA being far more important. And these people also have an ANA, as do the rheumatoid patients get ANA. And occasionally the lupus patients will get a rheumatoid factor, and occasionally they will get an SSA and an SSB. I will leave out scleroderma and myopathy as they will take a lot of time and I can address them independently. Thank you, and if you'd like to find out more about the diagnosis of lupus, rheumatoid arthritis, and Sjogren, stay tuned for the next lecture.